Endometriosis is a common gynecologic problem. It's the abnormal location within the body of normal endometrial tissue. While not all patients with endometriosis have symptoms, it is associated with pain, scarring, and infertility. Endometrium is the tissue that normally lines the interior walls of the uterus. In response to the normal cyclic hormonal events, the lining thickens, then splits off its most superficial layer, which is shed during the menstrual flow. Women with endometriosis have patches of normal endometrium located outside of the uterus. The most common locations for these implants are on the ovary, the uterus and fallopian tube, anterior cul-de-sac and round ligament, the posterior broad ligament, posterior cul-de-sac, and uterosacral ligament, also the sigmoid colon and the appendix. However, endometriosis can be found virtually anywhere in the body, including sites quite remote from the pelvis, such as the lung, vertebra, and skin. The specific cause of endometriosis is not known, but several theories can, in part, explain the existence of endometriosis. Two of the more popular theories are the implantation theory and the coelomic metaplasia theory. According to the implantation theory, during menses, some reflex of menstrual products back through the fallopian tubes occurs. Viable endometrium can land on a favorable site and, if tolerated by the patient's immune system, can establish enough of a blood supply to live and respond to the cyclic ovarian hormones. The coelomic metaplasia theory involves the peritoneal cavity containing some cells that have retained their undifferentiated nature and, given the proper stimulus, may grow and differentiate into endometrial cells. The exact incidence of endometriosis in the general population isn't known. For women undergoing gynecologic surgery, the incidence varies depending on the population, the type of surgical procedure, and the skill and diligence with which the endometriosis is sought. Endometriosis is found between 6% and 43% of women undergoing sterilization. For women undergoing laparoscopy for pelvic pain, endometriosis is found in between 12% and 32%. For women undergoing laparoscopy for infertility, endometriosis is seen in 21% to 48%. About 50% of teenagers undergoing laparoscopy for chronic pelvic pain or dysmenorrhea are found to have endometriosis. Classically, women with symptomatic endometriosis present with a chronic history of steadily worsening pelvic pain, usually more than 6 months. It's worse with menses and sometimes worse with ovulation. It may be focal or diffuse, but its location is usually constant. The pain may be aching, cramping, or both at different times. A second classical symptom is painful intercourse on deep penetration. The patient will tell you she feels him hitting something deep inside that is very tender. If she redirects the angle of his thrusting or limits the depth of his penetration, she may be able to avoid the pain. Less common is the complaint of painful bowel movements. If implants are located on the rectosigmoid or close to it along the uterosacral ligaments, then she may experience pain while actually passing her stool. About half the women who are demonstrated to have endometriosis have no symptoms at all. The classical physical findings include unusual tenderness and thickness or a dough-like consistency in the adnexal areas. It includes tender nodules along the uterosacral ligament, usually appreciated best on a combined rectovaginal bimanual exam. There may be tender nodules at the junction of the bladder and the uterus or tender nodules over the uterine corpus. Many women, particularly those with asymptomatic endometriosis, have no positive physical findings. There are no laboratory tests that are specific for endometriosis. However, we can make some generalizations. Some women with endometriosis have a persistent complex or solid adnexal mass on ultrasound, CT, or MRI. These endometriomas can assume a passable resemblance to almost any adnexal neoplasm. This means that the differential diagnosis for virtually any adnexal mass would include endometriosis. Most women with endometriosis will have an elevated serum CA-125. This chemical is released anytime there is peritoneal irritation from any source. The diagnosis can be established clinically, surgically, and/or histologically. Clinical diagnosis is established by a convincing history that is reasonably close to the classical description, accompanied by physical findings that are very suggestive of endometriosis. The accuracy of a diagnosis based on clinical findings is generally good and occasionally not very good. Surgical diagnosis is made by visualizing typical endometriosis implants in the typical places endometriosis tends to grow in. The visual indicators of endometriosis include deep red, slightly hemorrhagic sites, white puckering of the peritoneum, brown powder burns, translucent blebs, defects in the peritoneum, polypoid growths, and dense scarring of the ovaries, tubes, and cul-de-sac. This may be done through laparoscopy or laparotomy. A surgical diagnosis is more reliable than a clinical diagnosis, but not always consistent with a histologic diagnosis. Histologic diagnosis depends on the microscopic confirmation of endometrial glandular and stromal cells in an ectopic location. This is highly specific but requires surgical risk to obtain the specimen. At times, the endometrial cells can be elusive, particularly if the patient has been treated with medications to suppress endometriosis. It's common for there to be obvious endometriosis at the time of surgery, yet the biopsies will be negative. Some gynecologists feel that before initiating therapy, all patients in whom the diagnosis of endometriosis is entertained should undergo laparoscopy. Others feel that this is an unnecessary and dangerous overreaction and reserve laparoscopy for those in whom conservative management has failed or for whom there are other indications for laparoscopy, such as infertility. Untreated, endometriosis can worsen, regress, or stay the same, but more often it's progressive. Some life events have a favorable influence on endometriosis. Pregnancy and breastfeeding, for example, suppress endometriosis. Birth control pills, even if taken cyclically, usually suppress endometriosis, particularly if the endometriosis is minimal, mild, or moderate. At menopause, deprived of its hormonal support, endometriosis usually regresses, regardless of whether or not estrogen replacement therapy is used. Endometriosis has essentially no malignant potential. It is a problem only because of its potential for causing pain and scarring and its association with infertility. Generations of gynecologists have recognized that among infertile women, endometriosis is relatively common. Probably between 25 and 50% of infertile women will have at least some degree of endometriosis present. It's easy to understand how someone with severe endometriosis, including dense pelvic adhesions, might experience difficulty in achieving a pregnancy. More difficult to understand is why someone with one tiny endometriosis implant on the sigmoid colon would also experience infertility. The answer may lie in the complexity of endometriosis. Rather than blaming the endometriosis for the infertility, it is certainly possible that there is some other yet unexplained factor that predisposes the woman towards developing endometriosis and also predisposes her towards infertility. Severe cervical stenosis, for example, could promote a large amount of retrograde menstruation, setting her up for endometriosis, and also interfere with normal sperm transport through the cervix, decreasing her chance for fertility. There is no single best management for all women with endometriosis. Treatment must be individualized. The primary factors we consider, however, are 1. The need for preserving childbearing capacity, 2. The severity of her symptoms, 3. The presence or absence of infertility as a clinical concern for her, and 4. Her age. For example, a 35-year-old woman with severe symptoms and no desire for any further childbearing might be best served by a hysterectomy. The same woman at age 50 might prefer to go with medical therapy until menopause, when the symptoms will go away. The same woman at age 40, but with mild symptoms, might do well on birth control pills. Birth control pills exert a number of beneficial effects, particularly on mild or moderate endometriosis. They generally reduce the heaviness of the menstrual flow and its duration, reducing the amount of retrograde menstrual products. They provide a powerful decidualizing effect on the implants by virtue of their strong progestin. This discourages further growth of pre-existing implants. They reduce the levels of circulating estrogens, particularly estradiol. By inhibiting ovarian function and providing add-back estrogen, the serum estradiol levels in the blood are usually a little lower than before the birth control pills were taken. Lower estrogen levels ease some of the hormonal stimulation of the implants. When taken continuously, the birth control pills stop the episodic hormonal withdrawal bleed that occurs both with the normal endometrium and also with the endometrial implants. For severe endometriosis, other more powerful medications or surgery are often needed to be effective. It usually takes 3 to 6 months of continuous birth control pills for the patient to notice a significant benefit and up to 12 months to achieve maximum benefit. Birth control pills are relatively inexpensive, making this treatment choice very affordable for most patients. In the area of GnRH agonists, Leuprolide induces a temporary and artificial menopause with inhibition of ovarian function. The bad part of that are the side effects, including hot flashes, night sweats, vaginal dryness, and other menopause symptoms. The good part is that deprived of their estrogen support, endometriosis implants regress and may disappear. Many physicians will provide add-back estrogen to their endometriosis patients who experience significant menopause symptoms. This add-back estrogen is a very small dose and does not apparently reduce the beneficial impact of Leuprolide, but does provide significant relief of their annoying symptoms. Most patients taking this medication will notice a significant improvement of their symptoms in 3 months, and by 6 months they feel very good. After 6 months, the medication needs to be stopped, although another course can be taken later if needed. Leuprolide is moderately expensive, a potentially limiting factor for some patients. Another treatment option is danazol. This is a cousin of testosterone and has both direct and indirect effects on endometriosis. It directly inhibits endometriotic implant growth through its powerful decidualization properties. It suppresses the secretion of pituitary gonadotropins, resulting in inhibition of ovarian function and lower estrogen levels. It also blocks steroidogenic enzymes. The two main problems with danazol when used for treatment of endometriosis are its high cost and significant side effects, including weight gain, masculinizing side effects, and depression. However, it is very effective in treating endometriosis, and few patients stop it even if they experience side effects. It's normally taken for about a year before stopping it. Progestins can inhibit pituitary release of gonadotropins, blocking ovarian function, and have a strong decidualizing effect on endometrial implants, limiting their growth. Both properties are valuable when treating endometriosis. Progestins seem to be about as effective in treating endometriosis as birth control pills, but are somewhat less well tolerated. Weight gain and breakthrough bleeding are the biggest problems. It's not particularly expensive, and it is a reasonable choice for someone wishing to avoid surgery and birth control pills, but intolerant of danazol or leuprolide. Conservative surgery means surgically removing as much endometriosis as possible, but within the limitations of preserving childbearing capacity as much as possible. This means leaving the uterus, tubes, and ovaries largely intact, but removing all endometriosis implants that can be safely removed. Conservative surgery is the best choice for most infertility patients, as none of the non-surgical treatments has been found to improve the patient's fertility at all. In contrast, conservative surgery will achieve 40% to 60% post-surgical pregnancy rates, depending on the severity of the disease. Definitive surgery involves a hysterectomy, with or without removal of the tubes, ovaries, and other sites of endometriosis. Definitive surgery gives the greatest chance of permanently curing the pain of endometriosis, but necessarily involves giving up any chance for future childbearing. Controversial is the role of removal of the ovaries. If you remove them, you will achieve a slightly higher cure rate than if you leave them alone. However, you'll create a surgical menopause and without treatment create menopausal symptoms. For this reason, many gynecologists prefer to leave the ovaries in. Other gynecologists prefer to remove the ovaries with the intention of starting estrogen replacement therapy immediately after surgery. The addition of these small amounts of estrogen are apparently not enough to further feed the endometriosis.